So now this guy liked your answer and he decided to make an appointment to see you on Monday. And this is a nice little cartoon representation of this 57-year-old guy. Got the Milwaukee tumor gut going, and looks like he hasn't exercised. No ultra marathons for this guy, Vince. So he tells you he's 57-year-old male accountant. His chief complaint is bilateral lower back pain, which radiates into both buttocks and down both posterior thighs, not distal to the knee. It's a constant dull ache. He rates it as an 8 out of 10, says it's worse in the morning or after sustained sitting with his job, and it is getting worse overall. Any walking greatly aggravates his pain. He gets a bit of relief if he just goes recumbent. But sitting's worse, walking's worse, mornings are worse. He's had back pain off and on for over 20 years, but this episode has been constant for the past 4 weeks. So you get a kind of a sense of this guy, who he is and what's going on with him. He's using NSAIDs, just over-the-counter pain meds with marginal relief, and he's not received any other care. So he takes the NSAIDs pretty consistently, but they only give him a little bit of relief from his back pain. He doesn't exercise at all. He's very sedentary. He's an accountant. And when he's not doing accounting, he watches TV and eats chips. So he's really not active at any level. His past medical history is significant for hypertension managed by medications. He also takes a statin daily and for cholesterol, and he also has been told to take a baby aspirin every day, presumably for its anticoagulant effects. He was told he's pre-diabetic, but he wasn't put on any medication for that. He eats a lot of carbohydrates, a lot of fats, and he does drink and smoke socially. You gave him a start back questionnaire, and he scored a medium risk for chronicity. Remember, start back, it's that 9-item, we used the 9-item screening questionnaire, and he scored more than 4, so you did the subscale score, and it put him in the medium risk of chronicity category. So what else would you want to know? And you can either type in your answer, and David, if you could read those out, or if you want to just unmute and throw out some ideas, I'd be curious, is there either of these two questions? What else would you want to know about this guy? And what are your concerns? Just from that short history. And feel free to jump in. Anybody.
John, could you put the history slide back up if possible?
Oh, sure. So NSAIDs, sedentary lifestyle, past medical history, looks like cardiovascular stuff, pre-diabetic, high-fat diet, the lake, first in the morning. Gets a bit of relief laying down.
I guess I'd ask if he has any bowel or bladder dysfunction.
Yeah, no, not that he's been aware of. No. And it looks like, did someone type in an answer? Let's see.
Cancer history?
Oh, cancer history. No. Family history of cancer, but none with him. And he doesn't remember the details of the family history. Just somebody in his family had cancer. He doesn't remember who. Nobody immediate. No immediate family members.
He doesn't know the onset, the cause of onset. Was it kind of insidious?
Yeah, insidious onset. That's a great question. Insidious onset, he's had back pain off and on, so he'd get a little and not worry too much about it. But this episode has just stayed and gotten worse, but there was no precipitating event.
Was he a more consistent smoker prior to being a social smoker?
Yeah, when he was young, when he was in his 20s, he smoked and then kind of just stopped, but then went back to it now more as a social event. Whenever he's with friends, he's not like a two pack a week, but he's probably going through a half a pack to a pack a week.
Are there any other review of systems findings like related to respiratory issues or significantly worse pain at night?
Excuse me. No respiratory complaints. He feels horrible by the end of the day. And when he lays down, though, he does get a little bit of relief. It will wake him at night occasionally, but it's not like it gets worse at night than it is during the day.
Did he have the Milwaukee tumor removed?
No. He's feeding it. He drinks beer.
And one more thing, just based on his age and his smoking history, I think current preventive guidelines suggest that he could have been offered like an ultrasound at some point in time for abdominal aorta. Has that ever been done?
You don't have. He doesn't remember if he's had that particular kind of study done. He did know his family doc worked him up for his cardiovascular history in the past, but he doesn't think he had an ultrasound study done.
Vince comments, any recent sickness, infection, or illness preceding the pain?
Great question. No recent systemic illnesses.
Walking up or down hills aggravates the pain? Question mark. That's from Nigel.
Yeah. Well, again, he feels a little bit better leaning a little forward, but if he keeps bending forward, it feels much worse. So like climbing stairs, he's okay the first couple, and then it just feels like it gets worse. He seems to feel a little worse coming downstairs. He hasn't really done hills. He avoids hills. He avoids walking.
Right. So in terms of directional preference, it would seem that he's averse to prolonged flexion of the trunk.
And extension. Yeah.
Okay.
He doesn't, he tries to stay in his narrow zone of comfort and not move much beyond that. Is there another question typed in, David?
Yes. So first one is there any weakness?
Only because of pain that he's aware of. He's not aware of any specific weakness, but his back feels like it kind of gives out, and his legs will kind of give out when he really hurts. So he'll get a shot of pain and it feels like everything gives out. But weakness per se, he's not really aware of, other than his legs will give out on him. Are you still there, David? It looks like your video is frozen. Oh, is that me that froze?
No, I can
Dang.
see it. You're moving.
Okay.
I think that's David.
All right, great.
The other questions are, will you give physical exam findings, or should we ask for those?
Yeah. No, we're going to do that. We're going to do that next. I just wanted to get thoughts about the history.
And there's a question from Diego that says, has he tried any types of treatments in the past?
Yeah. In the past, because he's had this for 20 years. Yeah, he's gone through some physical therapy in the past, which, the episodes went away, so he assumed it helped. And he had a chiropractic treatment in the past, which helped. The episode went away. And he did some muscle relaxants in the past for an episode, but each of those episodes subsided, so he assumed what he had done had made it go away. So he's had a little physical therapy, a little chiro, nothing ever consistent. Once the episode was gone, he was gone. So anything you're concerned about this guy now, given that, Are there any concerns?
When you say concerns, just general red flag
Yeah.
concerns?
Anything, yeah.
Sure.
I mean, it doesn't even have to be a red flag. But I guess I'll go into it. I mean, he's got hypertension. He's on a statin, a baby aspirin. He's pre-diabetic. He's got a horrible diet. He smokes and drinks.
Right.
Oh, that's got to be addressed with this guy.
Yeah.
The back pain
think-
aside. Yeah.
I think some of the other concerns we address might happen as you're explaining the physical exam. Yeah.
Yeah, good. Okay,
But
good.
straight off the bat, as far as one, and you probably caught on to where I was going with that, just given that history and severity of pain, one of the concerns I would have would be for some sort of abdominal exam or, palpating, listening to the abdominal aorta.
Absolutely. Absolutely. Good. Yeah, we keep losing David Payton. I'm not sure why.
Hey, we seem to be doing great without him. Keep going.
Okay, great. All right, now let's jump into a few exam findings. He's 5'6" and he weighs 205 pounds. He looks pale and diaphoretic. His flexion antalgia, changes position frequently. He seems very uncomfortable. He seems anxious, says he's worried about missing work. No support from family members relative to his back problems. They don't seem to care that he's hurting. He wants you to, give him something that's stronger than the NSAIDs for his pain because he wants to keep working. And he's hoping you'll give him a new prescription because his back pain is bugging him so much. On exam, deep tendon reflexes were 2 at the Achilles and patella bilaterally. With Babinski, he's got down-going toes. Straight leg raise gave him back pain and buttock pain at about 40 degrees bilaterally. Both, raising either leg reproduced some back and buttock pain. No sensory changes in the lower extremities. Sacroiliac stress test was positive for back pain bilaterally. So it just hurt locally over the SI region when you stress the SI joint. Lumbar range of motion was globally restricted by more than 50% in all directions, with most pain when he went into extension. So everything, he wouldn't let you bend him in any direction very far, and he complained the most when you extended him. You did repeated end range loading and extension, and it really aggravated his pain, back, buttock, and thigh, so you stopped. Repeated end range loading and flexion was less painful than extension, but he wouldn't keep doing it because he said it just hurt too much once he got beyond so many degrees of flexion. You tried the hip extension test with him prone, and he hyperextends his trunk to do it and shifts his pelvis. So it's the only way he could get that test done. And then he becomes very agitated and says, everything you're doing is making me worse. I shouldn't have come to you. And he looks even worse than he did when he walked in. So now, what else do you need to know? And what are your concerns?
Any fever? Have you taken temperature yet?
Yeah, we're going to take his temp, and there's no fever. It's 98.6 degrees Fahrenheit. What is that? 37.1 centigrade for you South Africans. So no temp. I think, Drew, your concern about the aorta is, still fits.
Sure. Has he ever described it as pulsatile pain or anything like that?
No, it's a dull ache with
as
the sharp exacerbations.
And as far as just a more mundane physical sign, is there any sort of midline sill sign?
I'm sorry?
Is there any sort of midline sill sign of viewing him from the back?
Oh, no.
Okay, thanks.
Again, any concerns, and what else would you want to know about this guy?
John, something that would be a concern of a somewhat a non-clinical nature would be his agitation with the whole situation in conjunction with the fact that he's a mutual contact.
Yeah.
So that would set me on edge a little bit.
Yeah. I purposefully put that in because now it's not just his clinical situation. The guy's ticked off. And how are you going to deal with that? How are you going to handle the fact that you're working this guy up? You think there's something going on. You're not quite sure at this point. Is this a more serious problem? Is it something that I could manage? But you got a ticked off patient. Mm. So
yeah, it's if I could just give a brief anecdote in this connection before we proceed. I had a similar, well, I guess similar would be the wrong word, but a case of a similar nature in the sense that it was a reasonably close connection of a distant family member who came to see me by word of mouth. And the guy, he was about in his late 30s. It was years back. I can't quite remember all the details, but he was in his late 30s. He had 4 biological children. Three of his colleagues had recently been retrenched, and he was in the thick of handling the job responsibilities of 4 individuals. He had experienced some family stress, and he presented to me with neck pain. And so he came in for the treatment, and there were absolutely no red flags of any form on history or physical examination. There was nothing even of a yellow flag nature in that sense as well. But so I did the standard MSK treatment with some gentle cervical manipulation, and he went home, felt fine. 4 hours later, he presented to the ER with stroke-like symptoms. I don't quite know the history because I never saw him again after that. But they were transient, and he went. He presented to the ER, and it became extremely stressful for me because he was not just a patient, but there was this what appeared to be cerebrovascular incident occurring, or potential CVI, and the most difficult thing was that he was a distant family member. And I was regularly seeing the family members that were closest to him that I was seeing in another social context. And so it made it extremely difficult to handle, both clinically as well as then just in terms of the dynamics of the situation. So it would be akin to this.
Yes. That makes it worse when it's someone you...
Oh, it was 10 times worse. Oh,
yeah.
It was terrible.
Yeah. So it's in that same vein that I tried to present this, because now you've got a few decisions, right, that you need to address with this case. Are you concerned about an underlying systemic issue that would create some sense of urgency with referring him out, getting some additional testing or something? Or are you not concerned about that and say, okay, this does look like mechanical back pain that I think I can manage. However, I now have to deal with this psychosocial stuff whereby, one of the first things that you would want to do with that scenario where you've got an agitated patient now who's really in a lot of pain and isn't convinced that what you're doing is helping him, it seems to be making him feel worse. So now, can you reassure this guy enough or be empathetic enough that yeah, look, I apologize. This is the only way I can really get a better handle on what's going on with you is by challenging where, what's going to provoke your pain. I'm so very, very sorry. So now you've got to decide, am I more concerned that there's something potentially serious with this guy that I need to address? Is that exclusive to then dealing with this psychosocial stuff? Because what you'd want to find out is, well, okay, is he just being agitated because he's in so much pain and it's been going on for 4 weeks and it's getting worse? Is it because he's got no social support network, right? He tells you that his family doesn't believe that he's even hurting. Is there something else going on in his life? Is there another stress? Does he have financial woes? Is he going to be divorced? How much do you get into that psychosocial stuff with this guy at this point? I excuse me. I intentionally did 2 things with this as I put this together. I was vague about what seemed to be wrong with him. I have no clue. I didn't write this thinking this is discogenic pain, this is stenosis, this is facet, this is sacroiliac, or that there's an underlying, vascular problem with this guy. He's overweight, he's got a cardiovascular history, and he's pale and he's diaphoretic. I don't know if that plays a part in here. And then I gave him a psychosocial problem, where he's got no social support network. He seems stressed. He's in severe pain. And now he hates you. So it forces your decision-making in terms of prioritizing what's going on with this guy. And then sequentially how you're going to deal with it and address each of those aspects of this, right? So right now, we don't really know what's wrong with him totally. It looks like his back pain, if we subtracted out the pale diaphoretic and the cardiovascular history, if none of that were present, would any of these back complaints be troubling to you? Given he's no family history of no history of cancer, and he's got back pain that goes into his butt. He's a sedentary, out of shape 57-year-old accountant. Sounds pretty mechanical, right? Maybe it's disc, maybe it's facet, maybe it's a little early stenosis, maybe early degenerative changes. I don't know. But you've got that going on. Then you've got the fact that he's pale, diaphoretic, has a cardiovascular history, is on meds for those. Is anything there going on? Then you've got the psychosocial stuff going. He scored medium risk for chronicity. He's got no social support network. He's in a lot of pain. He's stressed and angry. So you've got to now figure out, is there something systemic wrong? You have to figure out, is this a mechanical problem that I can deal with? Get the diagnosis and figure out what to do. And then you've got to deal with all the psychosocial components of what's going on with this guy. And there isn't an answer. There isn't the next slide, I think, is thank you. My granddaughter. Because this is more real life in clinical practice. That you don't get an answer key at the end of your workday that says, okay, this one you did right, this one you did right, this one you did wrong, this one you got to do again. This is more what we see in clinical practice. So I don't have an easy answer other than to say, here would be my gut. And you can each challenge this and tell me if you think this is how you might handle it or what you might do differently. My gut would be, look, a pale diaphoretic patient who looks sick is always going to get first priority for me, just because, as I mentioned on last week's masterclass, that can burn you. If a person looks sick. They just look sick. Forget everything else that's going on with them and address that. I remember a young woman came in with lower back pain, across the whole lower back. She just looked sick. Well, I had the advantage. I did take her temp. She was running a temp, sent her over. She just had a massive UTI, urinary tract infection. And that was causing all of her back pain too, by the way. So when someone looks sick, my feeling is you got to address that first. Make sure that that's okay. At the very least, concurrent care where he's going to undergo something. Secondly, my guess is this guy just needs some empathy, because he's in a lot of pain and he's got no one that really is helping to validate him or to support him in this. And you could be that person. And my guess is if you did a much more follow the protocol of clinical reasoning and spine pain workup, you'd get a good sense of what's going on, whether this looks to be more discogenic, maybe stenotic, maybe he's early stenosis, maybe there's some SI involvement, whatever the case may be in that regard, and then deal with those components. The one thing I did give you, it looks like a poor impaired motor control. What we used to call dynamic instability is going on with this guy. So you could address all those aspects. So I think I would address the rule out systemic illness first, then go with a lot of empathy and reassurance to get this guy to understand that why you did your exam the way you did it and why it's going to ultimately help him, and then address the specific clinical problems that you identify with this person. But again, because of the psychosocial stuff, a lot of reassurance, a lot of support, a lot of empathy with this guy. That would be the take I would go with this case.
That's great, John. If I could, before we open up to the floor, we've got Don Murphy on the line. Don, I know you came in a little late on that. Any comments that you'd like to make on this case, on what you've picked up so far?
Late enough where I didn't get the whole picture, the whole history in the case, but certainly I like what John was saying. He was covering the nuanced aspect of that we so oftentimes see in patients, and the reading between the lines stuff. That you do your exam, you can take your history and get the clear answers from people. You can have questionnaire data, and that's great. But seeing between the lines sometimes is the challenging part. But sometimes that's the most important part. So that's the thing that jumped out at me about this.
Great. An aside comment that I wanted to make, John, is that one of the things that I found interesting growing up was the number of sickly, diaphoretic, older, fat men were in my life that were surprisingly healthy, and they just they look sick and about on the verge of a heart attack the whole time. But they just keep going. I remember one guy in particular. I used to play tennis at a club, and he was this German fellow who must have been in his mid-60s, who was enormous. And he had we used to call him the guy with the pale gills. And but you see that kind of thing, and it does kind of set you on edge in a clinical setting when you see a chap or a person, for that matter, just walking in looking sick. Don, how have you handled that kind of case when you've had people come through your practice and they've presented looking sick but with a supposedly mechanical issue?
Right. Yeah, that's really important, because early in practice, certainly I ran into that a lot, and I still do, but I feel more comfortable with it now than I used to. And there'd be usually an older man, sometimes older woman, overweight. They were beet red, like they're about to explode, and they're a smoker. And I kind of freaked about that because this person is not healthy. They're about to die, and they're going to die in my office. And of course, the absolute worst part, with the worst feature of a lot of these cases, is that they have no primary care doctor and hadn't seen a doctor of any kind in 20 years. I didn't like that situation at all. But what I, over time, the reason I gained a level of comfort is that, number one, simply just the process of gaining experience allows you to gain, when you've seen enough patients who are really are sick, as opposed to look sick but they're not. You gain an appreciation for what the difference is, and it's clearly different. The person who's sick, but they're sick because they have an illness, is different than the person who's sick because they're generally not healthy. And so getting a sense of those two, and I'll try to bring words to that, but over time you gain an appreciation for that. And you're more confident in your ability to distinguish those two. Also, that's a really important aspect of taking a good history and doing a good examination, and including auscultation, blood pressure, and temperature. Because if somebody seems sick and they have a fever, they're sick. They really are sick, truly sick. If they don't have a fever, you haven't ruled out the possibility that they're sick, but it certainly lessens the likelihood. And the same thing with taking their blood pressure. If they've got, blood pressure, 185 over 100, or 185 over 110, and they seem sick, they're sick. If they're normotensive, then again, the same thing with the temperature. It doesn't rule out that they could be sick, but it makes it less likely. So I think that, those things are the more concrete things that help you to gain more information. And also the history. Asking if they've been having fever, chills, rigors, those kinds of things. Do they feel generally ill? Because the other thing that you want to know is, if they're the heavy smoker, the people that we've been talking about, they've been like that for a long time. You're seeing them for the first time, but they've been like that for a long time. So it's really important to ask them, do you feel different than you usually do? Do you feel generally ill? Do you just not feel right? Have you been having chills or shakes? Those kinds of things. The history becomes really, really important in situations.
Mm-hmm. Oh, did we lose David?
Hey, everyone, can you hear me there? Yeah, go ahead. Anyone else who just wants to pipe up and make comments in this regard? Both at a clinical level and as well as handling the dynamics of the situation. Drew, was that you? Go ahead.
Yeah, it was. And just to kind of pick up with what Don was saying, because right there at the end when he said, do you feel different? I love that one. And there's also, one of the things that I've found through the years is the person who's sick oftentimes looks scared too. There's that different sense of not just scared of pain, but there's sometimes that extra look in their eyes, and it's hard to describe, where you can tell they have a concern that goes far beyond what they're really sharing with you in regards to their back pain.
Mm-hmm.
Yeah, that's really good. Because the important thing there to jump on to piggyback on what you just said, the thing about that there is that may not be forefront in their mind, that they're feeling worried or scared about how they feel it, because they're concerned about their back, and they know that they're not freaked out about their back per se. But so you may have to ask them, how are you feeling? Well, what's going on here? What do you think of this whole situation? And bring it out in them, because they may not volunteer that they may be, I have to see my primary care doctor and let them know that I don't feel right. But they may not tell you, because they're seeing you in their mind for their back pain, and they don't connect the feeling of illness with the back pain. And so be sure to really, and that's why I emphasize so much applying the concept of relationship-centered care. Really connect with the patient, get to know them. And you not only gain information by asking them questions, but you really get a sense of what's going on with them to a much greater extent when you really connect with them.
Yeah, that's a great point, Don. And just a quick anecdote in that regard from practice. I remember a late 30-something-year-old woman coming in and had pretty nondescript back pain, and no red flags that I could really get. And until I went in that direction, just what you had suggested of, what do you think is going on here? Why? Because I couldn't seem to abate any of her anxiety about her back. And turns out she had a relative who died of cancer with a similar complaint, a cousin or somebody who got back pain, went and got an x-ray, found out they had cancer, and ends up dying. So her big concern wasn't that she had back pain. Her big concern was, does my back pain mean I have cancer? So, and until you really can elicit from them, what do you think is going on here? What are you really most concerned about?
Yeah, and that's really good. And to piggyback on that, what's really important about that is that finding out if they are freaked out, if they are nervous, scared, finding out what they're afraid of. Because again, it's one thing to be afraid because they think the pain means I have cancer. It's another thing to feel like I just don't feel right. Something is not right about how I feel.
Yeah,
that's very, very different. And if they're really upset about something that there's really no reason to be upset about, great, you can talk them down from the ledge. But really find out specifically what it is you're concerned about, and that will really help you to distinguish the sick person from the scared person.
Mm-hmm.
John Hurley, go ahead.
Yeah, it was interesting to hear some of these comments. I had a patient who was in a great deal of distress, and he presented for neck pain upon the referral of his spouse. And he had been to his family doctor before he came to see me, and she had immediately kind of panicked because he was in distress and referred him to an orthopedic surgeon. His neck presentation was benign, but his distress was so disproportionate that I just slowed down a little bit and looked at him, and even just some simple stuff. He had like a rotator cuff pathology. I looked at his nail beds. They were very pale. His conjunctiva were very pale. And I treated his neck successfully, but said, I'm going to call your family doctor and get you back in to see her to get a little better workup. And a little quick aside, that the doctor was offended when I was really reaching out to just say, I need help. I'm a chiropractor. Please give this guy a nice workup. And she was quite offended or felt on the defensive that I even called her for to get some help. Turned out he did have a leukemia.
I'm a chiropractor. You should never have said
that. But she did do the workup, and he ended up having leukemia, and has had a good outcome. So that was good. But yeah, it was just hearing these comments. He was in great deal of distress, and I think he truly attributed his distress to neck pain. But just looking at him, I could tell he was very unwell, and luckily just we were able to get him back to his family doctor, get the workup, and he was well taken care of. So it was a happy ending so far.
Yeah.
Great anecdote. If I could quickly make a quick aside, dovetailing comment with this, the relationship-centered care and the comprehensive communication with a patient can also reduce the potential for litigation. John, you've mentioned that before. Mm-hmm. And that's something that, like in my case with that distant family member, it was the measure of communication that I employed, notwithstanding the difficulty of the situation, that enabled me to avoid litigation.
Mm-hmm.
John, any comments? You've mentioned some of the research in that regard.
Yeah, that one of the malpractice carriers would tell you that having a good, as Don suggested, having a good relationship with the patient is probably your best malpractice prevention.
Yeah,
Mm.
people generally don't sue people they like.
Yeah.
They sue people that they're mad at, that they felt did something bad to them and didn't care about them. That's the people they sue. They don't sue people they like.
No.
That's a really important point. By the way, we'll be covering this kind of thing, this protection of stuff in future master classes, because it's such an important topic, and one that we don't really get in school that well, for good reasons, because that's not the job of a institution. But where do you get it from? And that's why we've talked about before about how important that is to help people with incorporating that into their practice.
Yeah, one of the leaders nationally in relationship-centered healthcare happens to be a good friend of myself and my former business partner, Brian Justice, a medical physician by the name of Anthony Suckman. And Tony's website is rchweb.com, I believe. It's either rchweb.com or rchcweb.com, but it's all about relationship-centered healthcare. And Tony's got several articles you can get from his website that he's written on the topic. But his whole effort is to get healthcare providers and healthcare administrators to develop relationship-centered models of care.
We've got, we're just on the hour. We just passed the hour. So we've got just a few minutes to go. We've got a question here from Nigel. Perhaps we can address this and then wrap up, John. So the question is, when we are dealing with high-risk psych patients, what supportive measures should we take initially to address this? And when is it necessary to make a referral for interdisciplinary care?
God, Nigel, that's such a important question that there isn't an easy answer to. The easy answer to your question is, if a patient expresses suicidal ideology, then you urgently get them under psychiatric care. Short of expressing suicidal ideology, I've had this conversation with clinical psychologists and with psychiatrists as to what is the threshold for including behavioral health, whether it's psychological or psychiatric, within the care of a patient with pain. And nobody has given me an answer to the question of what is the threshold, short of suicidal ideology. So I think we should do a whole class on this topic, Don, on helping to help the clinician come up with a threshold for when you're going to include, what are the criteria for including behavioral health in the management of your case? When is you utilizing the principles of cognitive behavioral therapy, mindfulness therapy, and acceptance commitment therapy not enough? And when do you cross that line? I don't know, Don. So I don't have a good answer. Suicidal ideology is the easy answer. Short of that, I'm not sure when to bring behavioral health in. Yeah. How did you handle it?
What I would say, and you're right, John, that this can be an entire masterclass, just this topic, and should be that we'll strategize on how to best conduct that, because it's so important. And as a matter of fact, it can be more than one masterclass. Yeah. It's that important. And every patient is different, but what I will say is that the vast majority of patients, as John said, suicidal ideation, that's a big one. But short of that, which is fortunately is not very common, short of that, the majority of people who have significant psychological perpetuating factors are things that you can manage, that will improve with what you have to offer. Number one, doing things that helps to reduce the intensity of their pain, and number two, applies the principles of CBT and ACT in process of what you're doing. And so most people get better. So usually it's perfectly appropriate to wait for referral until after a period of time, a week or 2 or 3 weeks, to see if that's improving or if it's not. And John, to your point, when I was developing my system in Care New England, I had a full complement of psychologists available to me, and I sat down and I did ask them as well. And what I found out is that they weren't able to really provide concrete guidance either, because they didn't know, they never did anything like that before. This is brand new, and so I had to come up with my own strategy, and we'll talk about what that is, or make a decision as to when to refer somebody. And I ran that past them, and they really liked it. So that was my confirmation from them. That when I told them what I was planning, and they said, "Yeah, that's great. That sounds great." They gave me a little bit of tips here and there, but we'll get into that. It's really important.
Yeah, it's a great question, Nigel, and it's certainly one that warrants some relatively structured approach.